G'day, I'd like to let you know that Aussie Med Ed is sponsored by Tego. For most doctors, indemnity insurance is one of their biggest costs of practice. While many doctors are still with the same insurer they joined in medical school, many have made the switch to Tego and benefited from it. The team at Tego have told me that those new to private practice could qualify for 4 years of discounted premiums. To find out more about Tego, visit tego.com.au. That's tego.com.au. G'day and welcome to the Aussie Med Ed, the Australian medical education podcast, where we get to interview specialists in a variety of medical areas, asking their opinion on their certain conditions and obtaining their insight into how they diagnose and treat that condition. In these COVID times, it's a way of replacing a relaxed discussion around the hospital by allowing the listener to put forward questions to be answered or addressed on their behalf. I hope you enjoy the whole program and welcome once again to Aussie Med Ed. In this edition, we get to interview Dr Sam Whittle, a rheumatologist working at Queen Elizabeth Hospital and a research practitioner for the Australian and New Zealand Musculoskeletal Clinical Trials Network. We're going to hear about his approach to the treatment of rheumatoid arthritis for the medical student. Not only will this information be useful for the general practitioner seeing a patient on a regular basis, but also for the medical student revising for their exams or preparing for their OSCE examination. I'm Gavin, an orthopaedic surgeon based in Adelaide in South Australia. I'm the host of this podcast. I'd like to begin this podcast by acknowledging the traditional custodians of the land on which this podcast has been produced and pay my respects to the elders both past and present. Now, it gives me great pleasure to introduce Dr Sam Whittle, a staff specialist rheumatologist at the Queen Elizabeth Hospital, who's also involved in the teaching of medical students from the Adelaide University. He's also a research fellow for the Australian and New Zealand Musculoskeletal Clinical Trials Network, and his research involves living evidence, that is, systematic literature reviews and clinical practice guidelines that update in near real time as new evidence emerges. This provides guidelines to both clinicians and medical students alike. Welcome, Dr Sam Whittle. Well, welcome, Sam. Thanks very much for coming on Aussie Med Ed. It's great to have you on board. It's great to have a rheumatologist to actually answer some of our questions. It's an area that's really close to my heart as being a orthopaedic surgeon and a upper limb surgeon. The actual advances in rheumatology over the years have been fantastic and have actually changed the people's lifestyles. How do you approach rheumatology for a medical student?
Right. Well, firstly, thanks very much for having me, Gavin. And yeah, it's a real pleasure to be here. And certainly rheumatology has really changed over the last 20 years. When I started in rheumatology about 20 years ago, we really had very few therapeutic options for most of our inflammatory diseases. So that's changed considerably over the last couple of decades. So really a lot of our teaching these days really revolves around how we manage the inflammatory forms of arthritis with the newer medication. So that's something that's really important to us. But then having said that, much of what we do in rheumatology, the sort of the diagnostic side of things, really hasn't changed very much over the last 20 years. And so we really still rely heavily on the clinical evaluation. So history and examination really remains fundamental to rheumatology. And we think as the rheumatologists tend to think that we're sort of pure physicians in the way that we still prioritise history and examination in thinking about our diseases.
Okay, that's excellent. Look, let's start off by saying, how would you go about classifying rheumatological conditions? How do you think about your classification system when you think about rheumatological or inflammatory conditions?
Yeah, I try to keep it pretty simple. I think you can. You know, there are dozens of different types of arthritis, and I think we can make it too complicated sometimes. So I really try and keep it simple. So really, the first job in the rheumatology clinic when someone presents with musculoskeletal pain is to try to decide whether it's inflammatory or not. And that can usually be done on history and examination, but particularly on history. So really, any patient who presents with a painful musculoskeletal syndrome, the first job is to work out where you think the pain's coming from. So do we think that it's articular in origin, or is it periarticular, or is it muscular or otherwise? And then if you think it's a joint disease, then we really just try to decide whether or not we think it's inflammatory. And so the clues on history to inflammatory arthritis are things are very simple. You know, they're just things like worse with rest, improves with exercise, associated with early morning stiffness, associated with swelling and other cardinal signs of inflammation, improvement with non-steroidal anti-inflammatory drugs, and all those sorts of things. So then once we've decided that someone's got and inflammatory arthritis, then there's really not that many major categories of inflammatory arthritis. There is essentially rheumatoid arthritis, spondyloarthritis, the inflammatory connective tissue diseases like lupus, crystal arthritis, and viral arthritis. They're really the main ones, and then everything else is pretty much fine print after that. And probably the area where there's been the most confusion, or certainly speaking to medical students, where I see people finding it the most confusing is around the use of the term seronegative and spondyloarthritis and spondyloarthropathy. And there's all these terms that kind of overlap with each other and can be confusing. So again, I try to keep that really, really simple. So I tend not to use the word seronegative anymore. That really arose in an earlier era where we really only had the rheumatoid factor test, and it was felt that the presence or absence of rheumatoid factor was a good determinant of which category someone fell into. And now that's probably not so much the case, and certainly we've got other antibodies and other diagnostic tests that help to classify things anyway, like we've got anti-CCP antibodies, for example. And so the term seronegative can be a bit ambiguous. So I really like to just think about people as being falling either into the rheumatoid arthritis and then into the spondyloarthritis category. And spondyloarthritis is a really good umbrella term, and that encompasses several diseases that we've often thought of as being sort of slightly separate from each other, but in fact, mechanistically and clinically, they're probably pretty simple. So those diseases include psoriatic arthritis, axial spondyloarthritis, including ankylosing spondylitis, reactive arthritis, and enteropathic arthritis, that is the arthritis associated with inflammatory bowel disease. So if we use those really sort of simple headings, rheumatoid arthritis, spondyloarthritis, crystal arthritis, then that actually makes it pretty easy to categorise our patients.
So it's just those three main categories then, really. So the rheumatoid arthritis is the main group, just purely with a rheumatoid condition. Then you've got spondyloarthritis, and you've got your gout, your crystal ones, which include gout and pseudogout.
Yep, and then you've got your connective tissue diseases, and that of course incorporates lots of different diseases: lupus, scleroderma, Sjogren's syndrome, the inflammatory myopathies, and so on. So that's a different category. And while they often present with arthritis, the clue to diagnosing those is really that they've got so many other associated clinical features.
And what's the overall incidence of these sort of conditions? I mean, obviously the rheumatoid is the most common one, is it, or is it a connective tissue one more common? And overall, what's the incidence?
So rheumatoid's probably the most common. So it's probably around 1%. So that's a relatively common disease. If you lump all of spondyloarthritis together, it probably comes pretty close to rheumatoid, actually. Psoriatic plus axial spondyloarthritis is relatively common. Reactive arthritis, less so, and enteropathic arthritis, less so. So on balance, if you have someone who's clearly got an inflammatory polyarthritis, they're most likely just by probability alone to have rheumatoid arthritis, but psoriatic arthritis would come a pretty close second. The connective tissue diseases like lupus, particularly in this country with our ethnic mix, are much less common, but they can also be much more devastating if they're not recognised. So we have a high index of suspicion for them, but they're probably about an order of magnitude less common than rheumatoid arthritis.
So which group is lupus more common in then? Is it more the Europeans, is it, or?
It's most common really in all of the non-Caucasian people. So, and it certainly appears to be more severe on average in people who are non-Caucasian. So, for example, in the US, it's the African American and Hispanic populations who really suffer the most from lupus. Whereas here, in our clinic, we probably see it most often in people of Southeast Asian origin, where it can be quite devastating. But the autoimmune connective tissue diseases are fascinating. They really seem to affect all ethnicities to some extent or another, including Indigenous Australians, and often quite severely.
What other associations are there? I mean, obviously female is more common in rheumatoid, I believe itself, is it? Or
yeah, in general, for the just about all autoimmune diseases affect women more than men, and we're not entirely sure why that's the case. There's lots of lots of theories around the impact of hormones and other factors, but certainly women seem to be more frequently affected than men for most of these diseases. The main exception is ankylosing spondylitis, which is much more commonly a disease of men. So gender is definitely a risk factor for many of these diseases, although it's worth remembering that both genders can be affected with any of these diseases. So we never rule out a diagnosis based on gender alone. So that's a strong risk factor. And I guess the other risk factor that we really look for in the clinic, and one that's probably relevant, is smoking. So smoking is a risk factor for the development of many of these diseases, including rheumatoid arthritis. It's also a poor prognostic factor for many of our diseases. So we know, for example, in rheumatoid arthritis and also in ankylosing spondylitis, that if you stop smoking, that your response to disease-modifying drugs actually improves, whereas persistent smoking is associated with a poorer treatment outcome overall.
Is the pathology different between the different conditions? I mean, the actual joint destruction and tenosynovitis that occurs, or is it actually similar pathology that develops?
No, I think we're starting to understand that they're quite different most of the time. I think the big insight in recent years, particularly around spondyloarthritis, has been that the site of inflammation for spondyloarthritis is different to rheumatoid. And that really actually helps to explain some of the clinical features of spondyloarthritis. So if we think about rheumatoid arthritis, the inflammation really is in the synovium. So it's a synovium-based disease. So we get classical synovitis that occurs symmetrically in multiple joints associated with and persistent uncontrolled inflammation of the synovium can cause damage to the joints by eroding the cartilage and eroding the underlying bone. But in spondyloarthritis, the site of inflammation appears to be at the enthesis, so where the ligaments and tendons attach to bone. And so that explains some of the clinical features. So there are entheses all around the joints. So inflammation in the entheses will often spread into the joints. So that gives you your arthritis. But we also see enthesitis clinically in people with spondyloarthritis. So heel pain, Achilles tendinopathy, anterior chest wall pain, they're all common features of spondyloarthritis. And interestingly enough, we also see inflammatory disease in people with spondyloarthritis in non-musculoskeletal areas where there are entheses. So the ciliary body in the eye essentially acts like an enthesis. It's a ligamentous structure inside the anterior chamber of the eye, and that gets inflamed as well. And so we see about 1 in 3 people with spondyloarthritis over the course of their lifetime will develop anterior uveitis. So that's probably the sort of unifying explanation for the diverse clinical features that we see in spondyloarthritis. So now that we've recognised that, we now sort of have a good way of explaining the differences between these diseases, and it also helps to understand why we see differences in the treatments these days. In the olden days, in the sort of pre-biologic therapy days, we just lumped all these things together and we treated everyone with the same drugs in the hope that they would work. And often they did, but what we're seeing now that we've got more targeted therapies is that the effectiveness of the different molecules actually varies between the diseases, and that probably has helped us to understand the different mechanistic differences between the disease.
Excellent. That probably segues into how a patient may present into a different scenario, and basically introduces the idea of how a student might see a patient. If they're seeing someone in an exam, how would they present for, say, a rheumatoid one versus an ankylosing spondylitis versus gout? What sort of different presentations do they actually exhibit?
Yeah, so it's an interesting one for exams. I mean, I think that what we're often looking for our students to understand in an exam scenario is the clues on history to helping us to sort of construct an algorithm in your own mind for how to sort through these diverse presentations. And so it will often be someone who presents with some form of musculoskeletal pain. And then the task in an exam will often be to use the history to help narrow the differential diagnosis. And so the algorithm that we sort of want the student to use is pretty simple. I mean, it's, where are the symptoms? So are they articular symptoms or are they non-articular symptoms? If they're articular symptoms, where are they located? Are they in the limbs, in the peripheries? Are they in the limb girdles or in the axial skeleton? And is the pattern symmetrical or asymmetrical? And then is it monoarthritis and oligoarthritis or a polyarthritis? And just separating it into those things immediately narrows the differential. Clearly, we want people to really explore whether or not they think the symptoms are inflammatory or not, because the list of differential diagnoses for non-inflammatory pain is very different to inflammatory pain. Then it's worth thinking about the pattern of onset of the symptoms, so acute versus subacute versus chronic, and then whether or not it's the pattern of joint involvement is additive or migratory or simultaneous onset. And then finally, to look at all the associated non-articular or non-musculoskeletal symptoms that can help give clues. So for rheumatoid arthritis, it's typically very much a disease limited to the joints in the early phases. But in the very early stages, it can look very similar to viral arthritis. So we often expect the students to have thought about risk factors for viral disease like parvovirus, which we tend to catch from kids, or some of the arboviruses, which are associated with mosquito bites in certain areas where it's endemic, and so on. For the connective tissue diseases, there are a number of other non-articular features that we would typically see: dry eyes, dry mouth, mouth ulcers, Raynaud's phenomenon, and the like. And then for crystal arthritis, the sort of risk factors for crystal arthritis, particularly gout, the risk factors for gout include dietary and drinking habits, and so on. So having that kind of an algorithm in your mind of how to sort through these things in a kind of logical way is kind of the key to getting through a rheumatology station. And if you can sort of stick to that algorithm, then usually what you end up doing is narrowing down in the end to really only one or two or three plausible diagnoses, and then life's pretty easy after that.
So basically, if you can predict there's an inflammatory arthropathy, you've got those three main rheumatological spondyloarthropathies and also the crystal deposition disorders. Otherwise, the non-inflammatory ones include osteoarthritis or something like fibromyalgia type condition or a viral type arthropathy. Is that the main overall headings and things, is it?
Yeah, I mean, I think so the viral arthritis will often present in an inflammatory way that's really indistinguishable from rheumatoid. The best way to tell the difference between a viral arthritis and rheumatoid arthritis is the passage of time. So viral arthritis as a general rule is self-limiting, and the kind of arbitrary cutoff that we use is about 12 weeks. If you've had persistent inflammatory arthritis for more than 12 weeks, the chance of that being a self-limiting disease is really low. But in the early stages, it can be difficult to tell, and so that's when viral serology can be helpful, but doesn't always tell you the answer. But yeah, you're right. When it comes to the non-inflammatory causes of musculoskeletal symptoms, then the commonest ones by far are osteoarthritis and fibromyalgia.
Right. So the main concern I would have if I was a medical student coming up to the exam would be seeing a patient with monoarticular inflammatory arthropathy and trying to work out whether that's what the diagnosis is or whether it's actually just a simple osteoarthritic joint, such as a flame knee, and then knowing which way you're going to go, which pathway you're going to head down, whether it's going to be an orthopedic type pathway or it's going to be a rheumatological type assessment when you've got 10 minutes. What's the key question you would ask if you were stuck in that situation as a medical student? First few questions you would ask.
For a monoarthritis?
Yeah, monoarticular inflammatory arthritis versus, say, an arthritic knee or something.
Yeah. I mean, I think if you had to choose one question to ask to help you sort through a monoarthritis, it would be the duration of symptoms. So a chronic monoarthritis is almost always going to be osteoarthritis. But an acute monoarthritis has got a much more important set of differential diagnoses. And so this is where we really teach the students that any monoarthritis needs a needle put in it unless you've got a good reason not to. And that's a really good take-home message for clinical practice, but also for exam situations. So, a monoarthritis, you have to be thinking about infection until proven otherwise. And important differentials of an inflammatory monoarthritis include the crystal arthropathies, and the best way to diagnose crystal arthritis is again to do a joint aspirate and to demonstrate crystals in the synovial fluid.
Right. So the rheumatological monoarticular inflammatory arthropathy is not quite as common as a crystal deposition or a infection or a purely arthritic joint scenario.
Yeah, that's right. It's really rare, actually.
I'd like to let you know that Aussie Med Ed is supported by HealthShare. HealthShare is a digital health company that provides solutions for patients, GPs and specialists across Australia. Two of HealthShare's core products are Better Consult, a pre-consultation questionnaire that allows GPs to know a patient's agenda before the consult begins, with the aim to reduce admin and free up time during a consult, and HealthShare's Specialist Referral Directory, a specialist and allied health directory integrated into GP practice management software, helping GPs find the right specialist. You can find out more from healthshare.com.au.
To see any of the sort of autoimmune inflammatory arthropathies present with a persistent, or even to present at all with the monoarthritis, very occasionally you'll see a reactive arthritis or psoriatic arthritis, for example, present as a monoarthritis, but it's actually pretty uncommon. Typically, it's an oligoarthritis, and so the more joints you add to the mix, certainly the less likely it is to be infection, and the more likely it is to be something else.
I think you've answered the questions you'd ask on the history, and you've basically gone through the examination. Is there anything important, other things we have missed out on the examination you might be looking for as well before we move on to investigations?
No, look, examination is really important, and there's not a great deal of real secrets to the rheumatological physical examination. Certainly, a lot of people find it a bit mysterious, the kind of the voodoo that rheumatologists do in deciding whether there's synovitis present or not, particularly in the smaller joints. It's not really a secret to it. I think sometimes we try to make it look a little bit more complex than it is. And certainly, the more joints that you examine over your lifetime, and those of us who have been doing this for a while have examined a lot, the better you get at detecting subtle synovitis in small joints. But while people often worry that that's an important thing, the much more important thing is that people just remember to examine the joints. And this is really important in sort of general medical practice, particularly in undifferentiated settings, so in primary care, general practice, and in the emergency department, that when people present with any sort of medical complaint, that young doctors or any doctors remember to think about the musculoskeletal system and examine the joints. And so that's where, doing a musculoskeletal rotation during med school, where they're exposed to the musculoskeletal examination and the way that it's done, similar but also slightly different way by rheumatologists versus orthopedic surgeons. I think that's all really valuable to give people confidence to actually look at the joints. And, in the inpatient setting, in hospital, in the general medical ward rounds, to actually pull the sheets back and have a look at the feet and ankles and the knees. It's really important, and it's too often overlooked.
Okay, excellent. What about investigations you might order then? Obviously, we know the rheumatological factors and the anti-CCPs. What are the ones you tend to? What sort of group would you tend to order?
Yeah, so it depends a little bit on the clinical setting. So the best way to utilise investigations in rheumatology is to use them to help further your differential diagnosis. So there's often a temptation just to do this sort of mythical thing called the rheumatic screen, and that usually just involves people writing down every antibody that they can think of and sending blood off for that. And that's rarely useful because the tests that we use, all the laboratory tests, are neither perfectly sensitive nor perfectly specific. So they're most useful when you've developed a coherent differential diagnosis from the history and examination that narrows things down, and then you add investigations to try to narrow that further. So if you think someone's got a high likelihood of having rheumatoid arthritis, then really you want to try to confirm inflammation using inflammatory markers, and both CRP and ESR are helpful. CRP is often a little bit more helpful, particularly in the older patient. And then you want to use autoantibodies as well. So rheumatoid factor and CCP are the most important ones for rheumatoid arthritis. But again, 10 to 20% of people who've got rheumatoid arthritis don't have either of those antibodies, and so they certainly neither rule in nor rule out any of these diagnoses. We really advocate for people to use the other antibodies, particularly anti-nuclear antibody and extractable nuclear antigens, a little bit more sparingly. So if you really think that someone might have an autoimmune connective tissue disease like lupus, Sjogren's syndrome, scleroderma and the like, that's a good time to order an anti-nuclear antibody and use that alone because it's a very sensitive test. And then to use other autoantibodies that are more specific if it comes back positive or if there's a particular reason to do so. And that kind of rule of thumb also applies to the slightly more exotic antibody tests like ANCA. So I see a lot of people who have ANCA antibodies ordered when they've got really no symptoms or signs of vasculitis. And those antibodies are very specific to the systemic forms of vasculitis, which are important diseases but super rare diseases. And so there's always a concern around false positive tests. So so the take-home message is really to base your choice of antibody testing on the clinical presentation and on your differential diagnosis.
And I suppose you use ultrasound and X-ray a fair bit to help you diagnose joint destruction or synovitis as well, do you, or is that less commonly used?
So this is a controversial one because there are a few schools of thought on this. So I personally probably use imaging investigations less frequently than some of my colleagues. I think that from a diagnostic perspective, they're often not particularly useful. So plain X-rays are rarely useful early in disease because they really only show disease damage, and that takes quite a lot of time to accrue. So in someone who's only had symptoms for a few weeks or months, you're relatively unlikely to see any changes on a plain X-ray. Now, we sometimes do a plain X-ray to get a baseline to measure our longer-term outcomes against, but that's often the only reason to do it. Ultrasound's been really popular in recent years, and I can understand the popularity of it. It's accessible, it's safe, it's inexpensive for the most part, and it can show early or subtle signs of synovitis that sometimes you can't detect on clinical examination. So it's really attractive from that point of view. Unfortunately, though, it really rarely adds a great deal to a good, thorough clinical evaluation. So I don't use ultrasound that much, and there's a bit of research that suggests that adding ultrasound into your management algorithm doesn't have a huge impact on outcomes. So I'm not a huge user of ultrasound. Probably the imaging modality that I use most often early in disease these days is in the setting of axial spondyloarthritis. So people who've got either ankylosing spondylitis, also called non-radiographic axial spondyloarthritis. And that's where we tend to use MRI the most because we used to really be constrained just to use plain X-rays, and it takes many years for ankylosing spondylitis to cause changes in the sacroiliac joints in the spine on plain X-ray. But MRI can show really clearly inflammatory changes in the bone very early in disease, and that can be very useful in actually ruling in or ruling out a diagnosis early in the piece. So that's been the biggest change in my imaging practice over the last 10 years or so has been the more liberal use of MRI in people who've got inflammatory back pain.
Excellent. And now we'll probably progress to the treatment. What are the main category of drugs you use? Obviously everyone knows steroids, but how do you divide the other ones into different groups?
All right. So we've got so this is where we've seen the biggest change, in recent years. So for a long time, we've always had the non-steroidal inflammatories. So they remain our friends, although we are mindful of their potential for toxicity. Similarly, we've had cortisone since the late 1940s, and that it's hard to imagine a world without steroids. But again, we're very acutely aware of their potential toxicity. And we've had disease-modifying drugs really for more than 50 years, actually for longer. Really, we've had hydroxychloroquine and sulfasalazine since the 1930s. But it was really only in the 1980s that methotrexate and other disease-modifying drugs really gained traction in the treatment of rheumatoid arthritis and other forms of inflammatory arthritis. And that was how things stayed for about 20 years. But now we've really got three classes of disease-modifying drugs. So we've got the so-called conventional synthetic DMARDs. So those are the ones that we are most used to. That's methotrexate, sulfasalazine, hydroxychloroquine, leflunomide. And now over the last 20 years, we've had the second class of medications, and those are the biological DMARDs. So that includes a whole array of different molecules that are targeted. So the TNF inhibitors, we've got inhibitors of IL-6, IL-17, IL-23, and various other molecular targets.
These are interleukins. Interleukins is IL.
Interleukins? Yep. And then even more recently, we've had a group of medications called the targeted synthetic DMARDs. And so these are oral medications that specifically target the intracellular signaling pathways, the JAK pathways, that are used by inflammatory cells. And so they also very specifically can switch off certain parts of the inflammatory immune response. So we've suddenly got all these different classes of medications. So the conventional synthetic DMARDs, targeted synthetic DMARDs, and the biological DMARDs. And that's had really a revolutionary effect on our ability to treat not only rheumatoid arthritis, but also spondyloarthritis, vasculitis, and some of the connective tissue diseases. So, and that's what's made it really a very exciting time to be involved in rheumatology.
And what ones of those do you think the GP and the medical student would need to know? I mean, which ones? Obviously, we need to know all these biologics. There's probably special indications for them, and probably has to get special approval. What would be the main ones to know? There, obviously, the non-steroidals, the steroids, and then the more basic ones, are they?
Yeah, I think it's difficult to know how much people should know, because we're just seeing, not only in rheumatology, but across all of medicine, this explosion in the number of medications. And I think for the generalist, life's getting more and more difficult to know how much you should know about all these different medications. I think for a medical student in particular, it's really important that they're across the conventional DMARDs that are used most frequently. So methotrexate in particular, so in rheumatology, we refer to methotrexate as our anchor drug, meaning that it anchors the treatment for just about everyone with our diseases. So it's the first line disease-modifying therapy in just about everyone, and when we use combination therapy, it's usually a part of it as well. So it's probably important for everyone to have a good working knowledge of how methotrexate is used and what its potential toxicities are. It's often had a reputation as being a sort of toxic drug, and in fact, when used properly, it really is a very safe drug, but there are some tricks to it. The most important thing that everyone who uses methotrexate or prescribes methotrexate or has a patient with methotrexate needs to know is that it's used once a week. It's not a daily drug, and if it's used more frequently than once a week, it can be a very toxic drug. So everyone needs to know that. And the other tip for students for exams that they really need to know is it's a potentially very teratogenic drug. So there are some specific rules around how it should be used in women of childbearing potential that really students and everyone should know about, because there's really nothing more devastating than inadvertently using a teratogenic drug in a woman who falls pregnant. So I think knowing all of that around methotrexate's really important. The other disease-modifying drugs, I think, a lesser working knowledge is probably sufficient, although it's important to know a little bit about them. And then really for the biologic drugs and the targeted synthetic drugs and all of our newer drugs, it's probably sufficient just to recognise that they are fairly potent immune modulators, and so the infection is always a risk in patients who are taking any of our more modern anti-rheumatic drugs.
And any of those need to be stopped during or prior to surgery? Obviously, they increase the risk of infection. Are there any others that have any other side effects from whilst undergoing an anaesthetic or general procedure?
Yeah, it's a really good question. There are some guidelines around now that are pretty clear on how we should manage all these drugs in the perioperative period. And it's pretty straightforward, actually. So the conventional DMARDs, methotrexate included, we now advocate that they are just continued right through the perioperative period. In fact, the data on this are really interesting because it looks like if patients who continue their methotrexate or sulfasalazine or leflunomide all the way through the perioperative period for large joint arthroplasties, they actually have a lower risk of infection than people who hold their medication. So that's counterintuitive and fascinating. So we now advocate that they just continue through with no change.
Well, probably reduces the inflammation around the joint when they're having surgery.
Well, that's right. Yeah, that's the hypothesis. So having a disease flare is much worse for you than actually being on these medications for the most part. So that's a really useful thing to know. We just carry them through, and the same thing with steroids. We just continue that through. Now, in an ideal world, we would minimise the amount of steroid that people are using if they're coming up to elective surgery, but we can't always control that. But it appears to be the case now that just finding that low stable dose of steroids and continuing it through seems to be the best way to go. But the situation's different for the biologic and targeted synthetic DMARDs. So we ask people to skip one cycle of their biologic DMARD prior to their surgery. So the biologics are, for the most part, given by subcutaneous injection. Some of them are intravenous. And they're given at different dosing intervals, either weekly, fortnightly, monthly, or in some cases 3 monthly. And so essentially the advice at the moment is that you plan your surgery for when the next cycle would be due. So if you're on a monthly injection of a drug, so for example, golimumab is a TNF inhibitor that's given once a month, and say you were coming up for a knee replacement, and for example, if you take your golimumab injection on the first of the month each month, then you would, for instance, you might have your golimumab injection on the 1st of July, and then plan your surgery for the first week of August, and not have your injection on the 1st of August. So you just miss. So you basically have your surgery at about the time when your next injection would be due without having that injection, and that appears to reduce the risk of infection. And then you can restart the biologic usually a couple of weeks after the surgery, or when the surgeon's satisfied that the wound has healed sufficiently.
Excellent. Well, I think we've covered a lot today, and there's also so many other questions I would like to go through, but maybe I might be able to convince you another time to come back on. But this has been brilliant.
Be very happy to do a part 2 anytime.
Yeah, excellent. Certainly, I was hoping to discuss fibromyalgia, but I think there's another topic on its own. So we'll probably come back to that another time. There's a lot to take in. I really appreciate your time, Sam. It's been fantastic. You always present so well. A very favourite with the Adelaide University medical students, and really appreciate your time. Thanks again, Sam.
It's been a pleasure, Gavin. Thanks very much.
No worries. That's Sam Whittle. Thanks a lot. The information provided to you today is designed to complement the information provided to you in your local region and should supplement your readings and teachings in that area. Please don't take it as the only way of treating this condition or assessing a condition, but really as one of various ways of assessing these conditions. Please also be aware that the information provided today is really just general medical advice and isn't designed to actually be a source of medical information regarding your particular condition. Remember to consult your specialist or medical practitioner if you have concerns about a condition raised in this podcast. Well, thanks once again for listening to our podcast, Aussie Med Ed, or the Australian Medical Education Podcast. I really enjoy hosting this podcast. I hope you find it useful to hear a pragmatic approach to everyday conditions. If you have any questions or information you want to ask about us, or you'd like to put a suggestion for a topic, please don't hesitate to email us at gavin@med-ed.com.au. Once again, I hope you've enjoyed listening to it, and we'll look forward to hosting it next fortnight when we introduce a new topic. Thank you. Aussie Med Ed is proudly sponsored by HealthShare, a digital health company that provides solutions for patients, GPs and specialists across Australia, and Tego, offering medical indemnity insurance for doctors. That's tego.com.au.